Hello and welcome to clinicalpath.com. Today's topic is lipid metabolism and the dyslipidemia. Well, the central problem in biochemistry is what do you do with a product you need to do, like lipids, which are essentially hydrophobic when they're moving in an aqueous environment of the blood? And the answer is you have to bundle them into biochemically what is a colloid product. A colloid meaning a macromolecular structure that's dispersed evenly through a fluid. And to do that then, it has to build apolipids, which are also referred to as lipoproteins in a confusing interchangeable manner. And the structure of these then is about having a hydrophilic outside and a lipophilic inside. And the way it does this is it builds basically a soap bubble out of phospholipids. So we can see the phospho part is on the outside, so that works in the aqueous environment. And then the lipids we need to transport are here on the inside. So the inside is where we find our triglycerides and our cholesterol esters for transport. In addition to these phospholipids on the outside, there are structural blocks of cholesterol in these membranes. And then the regulation comes from the addition of very specific proteins, which are going to be our apolipoproteins, which are going to be critical for the signaling that is necessary throughout the body so that it knows how to handle with the lipids inside the center. So if we take a look at how to classify these lipoproteins, we can see that they're classified by density, by size, by lipid contents, and then by that key signaling protein that's part of the outer structure. Back in the day, these products used to be spun in huge centrifuges in an environment that allowed them to separate based on their density. And so that's why they have their names. VLDL for very light, because they were the least spun for far, and high densities, which of course would spin the fastest and be found at the bottom of the tube, and then intermediate and light. So this was all based on the original technology, which involved centrifuges. Chyle is the fluid that you get out of the thoracic duct. And so chylomicron is a really great name because this is the only particle we absorb during all of digestion that doesn't go through the liver, but in fact bypasses the liver to go in lymphatics, which is why after you eat, the fluid coming out of the thoracic duct is creamy white. One thing to note is density is based on the density of water. So the density of water is 1.000, and so when we take a look at chylomicrons, they are less dense than water, and so they float. And that's the basis of familial chylomicronemias that form a supernatant. When we take a look at the lipids, we can see basically density is proportional to triglycerides, and as we get smaller and smaller particles, we have more protein and less triglyceride. When we take a look at the actual proteins that become the critical signaling functional proteins, we can see that we have basically the B proteins, and then in HDL it actually has three. It has the structural A protein and then the transferable C2 and E, which is going to interact with the other lipoproteins. When we take a look at size, we can see there's actually a wide range of size, and even within any category, there's a lot of variability in size. When you just take a look at the variability in the chylomicrons, they can really decrease in size, overlapping with VLDLs as the triglyceride is removed. And this change in size actually has functional significance, because as the triglyceride is removed from the VLDL, enough has to be removed to make the IDL small enough to actually fit into the space of Dis in the liver, because that's where the liver lipase is going to act to further modify that IDL into LDL. So density matters, size matters, protein structures matter, and the amount of triglyceride matters. When we take a look at the apolipoproteins, you can see that the B protein here of B100 is not just structural in the wall of the lipoprotein, it actually is a ligand for the LDL receptor. And note as well that the E apolipoprotein is also a ligand for it. So you could actually call the LDL receptor correctly if you called it the B E/E receptor. That actually would be a workable name for it. And then we come down to C2, and you can see it actually activates an enzyme. So a few of the lipoproteins are just structural, but the others are actually very dynamic ligands and activators of enzymes. When we talk about the pathways of lipid metabolism, we're really going to be talking about three. We're talking about absorption from the gut, so it's outside the body and exogenous, and then we're going to go to energy distribution from the liver, VLDL. That's going to be our endogenous pathway, and then we're going to have the cholesterol recovery or reverse transport pathway. Now, I'm going to draw these out, so it's going to be sketchy, but I do that because I actually want you to see me draw it, because you're going to have to be able to draw it too. Okay, let's start at the beginning. Here we are in the bowel, and we're going to be taking from the bowel a single enterocyte. So here's our single enterocyte, and you can see it has a microvillous surface and a brush border. Let's start with the triglycerides. Remember that the first is dietary glycerides have to be emulsified in a micelle for the pancreatic lipase to work. And that pancreatic lipase is going to break them into triglycerides and free fatty acids, usually as a monoacyl glycerol. Once they're separate, these can be absorbed into it, reconstituted into triglycerides, and then they're put into the nascent chylomicron. While we're here, note there's also a separate cholesterol channel, so-called NPC1 channel, and that's going to allow cholesterol to be absorbed, and that's going to also be put into the nascent chylomicron. This then comes out of the lateral basal part of the enterocytes, and uniquely amongst absorbing substances is not actually absorbed through the portal vein going by the liver, but actually is absorbed in lymphatics and taken up in the thoracic duct and dumped straight into the blood. So once it's in the blood, here's our chylomicron, and the key apoprotein is going to be B48. Along comes HDL and is going to transfer to it C2 and E. And that's going to give us our key signaling for the tissues that can use fat, because there's really only three tissues that use fat. There's the liver, there's the lipocyte or fat cell, and then there's the skeletal muscle cell, including heart. And so this is where a very unique piece of metabolism is going to occur. So here's our capillary, and here's our two cells that are going to use fat. Here's our skeletal muscle, and here's our fat cell. And under the regulation of the fasting fed cycle, so think insulin, when there's a lot of insulin, these cells are going to produce lipoprotein lipase. And the two cells produce a slightly different lipoprotein lipase, and that's going to matter because those are different targets for drugs. And that lipoprotein lipase is going to be passed through the endothelial cell and anchored on the endothelial cell surface. So now when our particle comes through, C2 is going to activate that. Lipase is going to break it into triglycerides of free fatty acids and our glycerol, and that's going to be taken up by our cells and stored as triglyceride. What's left of that depleted chylomicron is now going to be our chylomicron remnant, and that's then going to have our constitutional B48, the E marker, but in fact the C2 gets returned back to the HDL. And that E then has the LDL receptor on the liver, and then the chylomicron remnant is going to be taken up by the liver and broken down. So when we look at this, we can see now that there are going to be three key diseases we're going to recognize from abnormalities in this pathway. The first of these is going to be abnormalities in the B protein. If you can't make the B apolipoprotein, here in the chylomicron it's B48, but it also includes the B100 of VLDL, then you literally cannot release the chylomicron. And so that's going to give us the disease of A-beta lipoproteinemia. We'll talk about that later, but these are little children that have failure to thrive, they have malabsorption, and all of these proteins carry all of the fat-soluble vitamins, and so they get vitamin deficiencies, especially E, which is going to give them eye and neurologic deficits. The second is going to be any defect in the C2 and the LPL. LPL defects are more common. And this is going to be the basis of the familial chylomicronemia. So we're going to have to talk about that. That's one of the really important diseases to take into the exam. And then the third is if we have defects here between the E and the receptor, and this is going to be the basis of familial dyslipidemia. There is a fasting state. Well, it starts in the liver, and when we talk about the hepatocyte, I always like to draw the hepatocyte this way because it actually interfaces with the plasma on two sides. So I always draw it with two villous borders, and then I do the little dent because that's where we're going to have our bile canaliculi. The liver then is going to make the distributing apolipoprotein, which is our precursor VLDL, and the key apoprotein is going to be B100. So the precursor VLDL is going to interact with our HDL, who is going to add on to it the C2. So with the B100 as the constitutional protein and the C2, that then becomes a full VLDL. And now we're going to see the same action that we saw with the chylomicron, because here we have our skeletal muscle and here we have our lipocyte. And again, these are going to produce the lipoprotein lipase, which is going to be on the surface of the endothelial cell. So now when our VLDL comes through, C2 is going to activate the lipoprotein lipase, and the triglycerides will be broken into fatty acids and our glycerol, and then reconstituted after they diffuse through the endothelial cell. Once it comes back out here, the C2 gets returned to the LDL, which now adds an E. So there's our constitutional B100, and there's our E protein. And the depletion of the triglycerides means that this is a much denser particle, so it is called an intermediate density lipoprotein. Back to the liver, this is now small enough to be inside the space of Dees, where the liver lipase now modifies it again, and that modification means it ends up as an LDL. Again, it has the B100, and again it has the E, and the BE are very strong signals to the LDL receptor, and so that particle can be taken up into the liver and processed. 70% of all the LDL receptors are found on the liver, and the other 30% are, for example, cells that are going to use it as a cholesterol precursor for steroid hormones, so that would be adrenal and the gonads, and then other various cells as they need cholesterol. But the big player for the LDL receptor is going to be the liver. So when we take a look at this pathway then, this then places three diseases onto it. The first is going to be if there's too much production of VLDL, then that will give us one of the fundamental causes of familial hypertriglyceridemia. The other thing to think about here is we're going to discover that HDL and VDL actually exchange lipids. So HDL will contribute cholesterol to VLDL, who will give back to the HDL triglycerides. And this is done with the cholesterol ester transfer protein. And that's why there's this intimate relationship between triglycerides and HDL, which isn't completely understood yet, but is fundamentally part of the pattern we see in metabolic syndrome, in which we see increased triglycerides and decreased HDL. So somewhere in here is a pretty good area to go looking for the defects in our metabolic syndrome with that centripetal fat, hypertension, insulin resistance, and dyslipidemia. That's a fruitful area to think about its abnormality. And then the last and most important one here is in the LDL receptor, because this is where we're going to have our hereditary monogenic familial hypercholesterolemia. And we're going to discuss that as a separate entity coming up. The third of the key pathways we have to do is cholesterol recovery, called the reverse cholesterol transport pathway. HDL is mostly made by the liver with a small contribution from the small intestine, and that makes a nascent HDL. And that nascent HDL particle is going to receive cholesterol from both macrophages and from just routine tissue cells as they balance the cholesterol in their membranes. And the addition of that cholesterol, which is a cholesterol ester, fills out the HDL, and so we have a mature HDL. Remember that HDL is going to exchange cholesterol for triglycerides with our VLDL. But the other key function is over here in the hepatocyte, HDL can disperse the cholesterol not through the LDL receptor, but through the scavenger receptor of the hepatocyte. And then obviously the hepatocyte can excrete cholesterol and bile salts to eliminate the cholesterol. So when we talk about how the body manages cholesterol, we can see that roughly 50% gets recycled through VLDL, which is going to end up at LDL, again going through the LDL receptor, and another 50% is going to go directly to the liver, where it's taken up through the scavenger receptor and can be excreted into the gut. So this is why HDL is so critical in preventing atherosclerosis, because it has the ability to take cholesterol out of the system and eliminate it from the body. So let's then just take a moment and talk about the specific diseases that we have to know out of these pathways. The first of these is A-beta lipoproteinemia. This is very rare. Somewhere between 100 and 200 cases have ever been described. But remember, we learn rare diseases when they teach us important principles, and so this is one of those diseases. This is a disease that arises due to a defect in the microsomal triglyceride transfer protein, which is the regulatory protein for the whole ApoB series. So that includes both the B48 of the chylomicron and the B100 of VLDL. And the significance of this is it not only leads to a decrease in fat absorption, but it also leads to a defect in the transport of the fat-soluble vitamins by the VLDL. So when we take a look at who this is going to present as, this is going to present in childhood as a failure to thrive. And because the chylomicrons can't be absorbed into the lymphatics, the failure to thrive is also going to be seen as a malabsorption, and these children have the typical steatorrhea of non-absorbed fat. But the key damages from the fat-soluble vitamin deficiency, and the most critical of these is vitamin E. And the failure of adequate levels of vitamin D leads to ataxia because of degeneration in the spinocerebellar and dorsal columns, but also blindness because they get a failure of development of the retina. And so the diagnosis of these children is going to present with a small failure to thrive, a typical malabsorption workup, but when you go take a look at the laboratory values, you're going to see an absence of both chylomicrons and VLDL, because both of those have ApoB proteins. If we did a biopsy of the small bowel, we would see that the small bowel lining cells, the enterocytes, would actually be full of lipids because the chylomicrons cannot be released from the cell. And really, there's no great way to treat this. It's going to be mostly a question of manipulating triglycerides in the diet and making sure that the child has adequate levels of vitamin E. Familial chylomicronemia, back in the old Fredrickson system, used to be called a type 1 hyperlipidemia. And this is a defect in lipolysis. Because remember, the key function of C2 was to activate the lipoprotein lipase in the capillaries of tissues that can use fat. So a defect in either the C2 or the lipoprotein lipase gives a failure of that step of lipolysis. In fact, about 80% of them are defects in the lipoprotein lipase, but the clinical picture of either is going to be identical. This is going to present due to the really high levels of triglycerides, which is actually not atherosclerosis, but is acute pancreatitis. And this is going to present before age 40 as befits a hereditary disease. Very common to also see it in childhood. Other things in addition to the pancreatitis is these children can present with xanthomas of skin, and they can also have abnormalities of the liver and spleen through poorly understood mechanisms. The diagnosis, well, obviously you're going to present in the emergency room with acute pancreatitis, but if you take a look at the blood you draw and you leave it overnight in the fridge, remember that chylomicrons are lighter than water, and so they float. And so you can see this creamy supernatant if you let their blood sit, because that rises to the top. Other things you can use to recognize, chylomicrons should only really be seen in a normal person when they're eating. Obviously in these people you can see it when they're fasting because they can't clear them. If you measure their blood lipids, they're going to show severe increases in triglyceride, which is over 90% of the chylomicron. Obviously there's going to be a genetic history here because these are an autosomal recessive defect, so probably 2 or 3 generations to be able to see repeats. When we talk about the treatment, really about all you can do is restrict triglycerides in the diet. Familial hypercholesterolemia in the old Fredrickson system was called a type 2 hyperlipidemia. And this is one of the most underdiagnosed diseases that we have. It is an autosomal defect in the LDL receptor. And this is a big protein. There have been over 1,600 different variants. So that means we're going to see a lot of different expression of the disease. It is the most common autosomal genetic disease that we see in our North American population. Quotes have been somewhere between 1 in 250 to 1 in 500. So it's really common. Other things that are going to give a similar picture to this would be when we have a gain of function mutation in PCSK9, which is the regulatory protein of LDL receptor, and more on that later. As well, we can see it if there are defects in apoprotein B, because remember, BE are key in binding these particles to the receptor. So anything related to LDL receptor, the regulatory PCSK9, or the ability to bind the receptor are all going to give us hypercholesterolemia. The critical part of this is right now, less than 10% of these are being diagnosed in our population. So over the next few years, I think there's going to be a major push to recognize this family disease. The other thing to remember is that because there are so many different variants, we're going to see what's called autosomal dominance with genetic dosing, meaning different variants are going to give us different severity of disease. We can see that if you get one from mom and one from dad, we're going to have a homozygous condition. And that's really a very severe condition. It's going to present typically with xanthomas of the skin by age 10. They're going to have coronary artery disease, and they're all dead by age 30. So this isn't going to be a disease that's going to be hard to recognize. The key disease we want to talk about is the heterozygote disease, because that's going to overlap with the normal polygenic disease of everyday hypercholesterolemia. So when should we suspect the heterozygote condition? And the answer is anyone has evidence of coronary artery disease before age 55 to 60. So if we think of over 65 degenerative malignant, anybody who's under 55, 60 should be investigated for this. Anyone that has an LDL cholesterol of greater than 190, that's getting pretty high, that person should be investigated. Obviously, it's an autosomal dominant disease, so anyone that has a positive family history should be investigated. And then the last is anyone that presents with xanthomas, because remember 75% of these have the very specific xanthoma of the Achilles tendon. So anyone that's showing up as xanthomas, this is a common enough disease that it should be looked for. When we talk about the physical exam, in addition just for looking for the atherosclerotic disease, looking for these xanthomas on the Achilles tendon is the key physical finding. And just a note, in the books they always show pictures of this yellow thing on the tendon. In fact, that's not the commonest. Most of the time you're going to have to palpate that Achilles tendon and just feel that there's an area of thickening, and that will be the commonest way you're going to diagnose it. As well, they can also present with xanthelasmas, but these are very nonspecific and really pretty common, so finding them isn't as helpful as you'd think. The key thing is to do the laboratory investigation. And in the laboratory investigation, you're going to see the increase in the LDL cholesterol. If it's over 500, that's going to be diagnostic. There's nothing else going to give you that high in LDL. And then after that, you do your genetic testing of the receptor. Obviously, the treatment has to be really aggressive. It's going to start with a high-intensity statin, and then quite quickly you're going to go to polytherapy by adding a PCSK9 inhibitor, and both of those are commonly used in this entity. If you still don't get the result that you need, you can even add a third drug, so you can add ezetimibe to block absorption at the level of the gut. But obviously these are very high-risk patients and need aggressive treatment. Just to point out, most of your patients with hypercholesterolemia are going to be polygenic as compared to the monogenic receptor defect we've been talking about. 90% of all the people with these defects are going to be polygenic. And so there's no single defect here, and these are going to be the patients where we work very hard on lifestyle activity changes and often monotherapy of the drugs. Familial hypertriglyceridemia, back in the old Fredrickson system, was called type 4 dyslipidemia. And we can see triglycerides are found in most of our apolipoproteins. So when we talk about the causes of this, they can be caused by an increase in VLDL production, but there are other defects as well. If we have a defect in our ApoE, that's going to be familial dyslipidemia, because that's not going to be able to clear the remnant chylomicrons. And then the other group of diseases that are going to be associated is if I have abnormalities in the C2 activation of lipoprotein lipase. So that's going to be my familial chylomicronemia, and that's going to be a defect in lipolysis in the capillaries of the fat-absorbing cells. So there's no single familial hyperlipidemia. When we take a look at what the patient looks like, the phenotype really looks a lot like metabolic syndrome. And remember, metabolic syndrome is the scourge of the Western diet, in which it starts with insulin resistance, or hyperglucosemia, if you want to call it that, plus we've got that fat, which is central pedal over the abdomen. It has hypertension. It has the abnormal lipids of increased triglyceride and decreased HDL. So familial hypertriglyceridemia sure looks a lot like that when you see those patients. The last thing we want to stop and talk about are secondary hyperlipidemias, because there are treatable underlying causes. The first is secondary hypertriglyceridemia, and the most important of these is hypothyroidism. Thyroid hormone is necessary for proper formation of the LDL receptor. And so hypothyroid patients will have elevated cholesterol because of this defect. We can also see hypercholesterolemia in nephrotic syndrome. The profound loss of protein in that disease affects production of all proteins, including the apolipoproteins. Then the last to remember is when you have hepatobiliary disease, that also is part of the cholesterol pathway for excretion, and they can get hypercholesterol states. When we talk about hypertriglyceridemia, these tend to be abnormalities of lifestyle. So when you see your alcoholics, diabetics, people with liver disease, and last but not least, women who are put on the birth control pill for estrogen, all of these patients can develop hypertriglyceridemia. The important thing to note is that, in general, triglycerides do not result in cardiovascular disease. So we're mostly going to be treating them for the consequences of the very high levels causing pancreatitis, or because it's associated with cholesterol damage. And so we can see most of the treatment here is going to be lifestyle before medication. Okay, let's just close out this discussion by using our pathways, which we've written our diseases on, to use them also to talk about treatment. Remember, always and ever, the first treatment of hyperlipidemias is going to be lifestyle modification. And that's going to be exactly what you think it's going to be. It's going to be exercise, appropriate weight, and appropriate diet all the way back to the usual fruits and vegetables. And, for all that we talk about it, it's really hard to do and is generally pretty unsatisfactory. So let's go through then and let's take a look at how do we remember our cholesterol lowering drugs by putting them onto our metabolic pathways. So let's start with our drugs that are related to the hepatocyte. So if we're going to draw a hepatocyte, remember we're going to draw it on two sides with a microvillus border, and there's our bile canaliculus here, because the liver is arranged in plates. And so on one side here, we're going to have our LDL receptor, which is regulated by PCSK9. And what drives the formation of the LDL receptor is the level of cholesterol inside the hepatocyte. So anytime we decrease the cholesterol, we're going to produce more of the receptors. Remember as well that the kidney can excrete both bile salts, which have a cholesterol foundation, and cholesterol itself into the bile. So let's talk about then where we see the targets for treatment. The cornerstone of treatment is going to be decreasing the synthesis of cholesterol. And so the common target for our statins, which absolutely are foundational for the treatment of cholesterol, is going to be the rate-limiting enzyme, which is our HMG-CoA reductase. Decrease the cholesterol, increase the receptor. The second new brilliant target that we have is going to be PCSK9 inhibitors, because PCSK9 causes the breakdown of the LDL receptor here in the cytoplasm. So if you can get rid of that inhibitor, then the receptor is much more long-lived. And then the last thing we can do is we can take the bile where it comes out into the gut, because that's going to come through our bile duct, and we can then add our sequestrants. So we bind the cholesterol and bile salts up in the gut, and they can't be reabsorbed, and that decreases the level in the blood. So that's going to be a classic example of cholestyramine. So the only thing that's missing in this discussion then is ezetimibe, and it acts at a totally different level. Remember, we go all the way back to absorption. Here's our small bowel, and here's our enterocyte. Remember that we have a brush border, and in that brush border, we have the cholesterol channel here, and ezetimibe can block that so that we don't get absorption of cholesterol through that channel. So then that gives us the 4 drugs that we have and a good visual idea of where they act in the metabolism. Okay, well, let's come down now and take a look at our cholesterol lowering drugs. So the first of these we're talking about is mipomycin. Let's just put it on our pathway. Remember that we're going to make our nascent chylomicron here with our B100 as the apolipoprotein. And then that's going to become a full VLDL when the C2 is added by our HDL. So here's our B100, that's the constitutive, and there's our C2. And C2 is then going to activate the lipoprotein lipase, which has been added to the capillaries by our muscle cell and our fat cell, themselves regulated through the insulin pathway. So that then is going to, C2 is going to activate the lipase, and after that comes out, we're going to have an IDL and return the C2 to the HDL, which is going to add an E, so the IDL can become LDL and cleared. So how do we manipulate then the triglycerides in this pathway? So we have 3 drugs. Mipomycin, in fact, here is going to inhibit the mRNA of our B100 synthesis. So that's going to decrease the production of our VLDL. Our fibrates are actually going to stimulate the muscle cell to increase the amount of LPL. And the reason that works then is, remember that the muscle cell is an end storage organ. Anything that goes into the muscle cell never comes out again because it's going to be burnt into it. So it's a final stage. So if we can increase the LPL, we can increase the amount of triglycerides going into the muscle cell where it will be burned in exercise, and that will work. So that's going to be the mechanism of action of our fibrates, which introduce that because they are PPAR alpha drugs that act at the level of DNA. So fibrate on muscle lipoprotein lipase. The other drug that we have is niacin, and niacin has multiple effects, but a nice way to think about it is that it's going to increase the lipoprotein lipase from the fat cell. So that then is going to increase the amount of triglycerides going into the fat cell, but we can see that gives us a problem because fat now is not an end organ, it's a storage organ. But the other thing that niacin does is it also inhibits the hormone-sensitive lipase. And that's a really big idea because what it means now is that we can't release free fatty acids. And it is an increase in free fatty acids showing that you've got a fasting state that actually stimulates the liver to make more VLDL. So niacin not only increases lipoprotein lipase for fat into the fat cell, but it's also going to block its release, affecting the liver production of VLDL. So those are 7 drugs that really are fundamental for one of the most important diseases. And then remember, the other things we've got to bring into this is you've got to be able to do the pathways for our beta lipoproteinemias. We've got to be able to do our familial chylomicronemias. We've got to be able to do our familial hypercholesterolemias with emphasis on the hereditary LDL receptor defects. And we've got to be able to do our familial hypertriglyceridemias. So when you can do those, you have your lipid metabolism and your dyslipidemias well in hand. So that's the end of this tape. Thank you for listening.